Hey everyone, it's Dr. Chris Shaver, host of the GI Show, and we are here with you for the GI Show. And we're talking about irritable bowel syndrome, which is a really important topic that you need to know about. In fact, I've titled this Understanding Irritable Bowel Syndrome for the first time because number one, I kind of want to demystify it for you guys and just sort of help you understand it on a kind of a core level. And also I don't want to really assume what you do know about it. And so I want to dispel any myths or misunderstandings that may be taking you down the wrong path in understanding and dealing with maybe your diagnosis of irritable bowel syndrome. So anyway, welcome. We are filming here at the lovely BGA Studios. And it is IBS Awareness Month. So I thought it was a perfect time to really delve into irritable bowel syndrome with you. Remember, our mission here is to educate and inform you. So I'm very excited to present to you my special guest, Dr. David Landy. Dr. Landy, would you join us, please?
Sure. Thank you very much.
Good to see you. It's really good to hear his perspective on a really important topic that we're talking about, irritable bowel syndrome. It is, as I mentioned before, April is IBS, Irritable Bowel Syndrome Awareness Month. And so I'm looking forward to getting your perspective. So a bunch of smart men and women get together every few years in Rome and define a lot of what we call functional gastrointestinal disorders like irritable bowel syndrome. And so the most recent version of the Rome criteria is that patients have to have pain. So they have abdominal pain and they have to have it frequently, so weekly for 3 months. And it has to be associated with 2 of 3 other criteria. One is the pain has to be associated with defecation, which means that it gets better or worse when they go to the bathroom, and or change in stool form, appearance, or change in stool frequency. So that's just kind of gives you kind of a sketch of sort of a diagnostic scheme for how it's diagnosed, IBS. So wanted to throw that out there. We'll also include that in the show notes. So testing. Talk to me about tests. This is, and there's not really a right answer in my opinion on how intense patients should be tested for really we're testing for other things because the classic teaching is that irritable bowel syndrome is a diagnosis of exclusion, right? We exclude other things that may require a different course of treatment. And the classic teaching has also been IBS is non-inflammatory. Other diseases of the gut that produce diarrhea and pain are often inflammatory. So there's some new information more recently that may sort of challenge those traditional teachings. But so testing, so this is not a right or wrong question for you. It's sort of like, what's your approach to testing in most patients with irritable bowel syndrome?
Okay. Well, there are some things that I just do. Like somebody comes in and it's an irritable bowel syndrome consultation. You know that's what they're coming in for, or maybe they're thinking something else, but maybe that's what it is. And so there's some things that I always do. I always check a CBC, make sure the patient's not anemic, and I'll almost always check a celiac panel. That should be done more in people with diarrhea predominant symptoms, but I tend to get that. And then we do additional testing depending on, if we think something else needs to be done. And I always tell my patients that a lot of the symptoms of IBS are similar to symptoms of other things, and like you said, it's a diagnosis of exclusion. I tell them that it's a diagnosis of exclusion, and if you think there's something else going on, then you have to do specific testing for those things.
Right. So, okay. Stool studies, when you check stool studies, what do you check for? What are you looking for? Anything in particular?
Usually, yes. Usually if their diarrhea is a predominant symptom, and say I don't think they need a colonoscopy, I'll check stool studies. And I will usually check something if there's any evidence of inflammation, like a fecal leukocyte or a fecal calprotectin. Sometimes I'll do that. And then Giardia, which is a parasite that can cause chronic diarrhea. It's a one cell parasite, not that uncommon. And I'm trying to think if there's anything else I usually check for. Those are the main things I would check for.
Maybe C. diff if there's an antibiotic history,
C. diff.
Or hospitalization history. You may check C. diff.
Absolutely, and especially if the diarrhea is really bad and they, like you said, antibiotics. I always ask about antibiotics and they've been in the hospital and risk factor for C. diff.
So while we know that IBS is a diagnosis that we can make with a good history, symptom-based diagnosis with some sort of basic core testing, are there symptoms that make you think, maybe something else is going on? The so-called alarm symptom. Talk to me about some alarm symptoms that make you sort of think, I need to kind of maybe do some different testing, go a little different direction, expand the differential diagnosis. What are some things that you hear in the office that make you think about that?
Right, and there's some that that I hear that I look for, and some that you can read about. And one of the main thing is bleeding. If there's blood in the stool, everybody gets very concerned about that, and we do too. We get concerned about that. Bleeding, weight loss. That's not a common thing. One thing that alarms patients sometimes, but mucus in the stool, but we don't consider that an alarm symptom because that's pretty common with IBS. Other alarm systems, one of the things that I consider an alarm symptom is, I don't really read about, but I consider an alarm symptom is that the kind of sudden onset of it. So like if they're going along and everything's fine, and then for the last 2 weeks or last month, or even if they can say 1 year ago it started, it started with this stuff. And to me, that's kind of an alarm system. And also, to me, also the severity, the high volume diarrhea, severe abdominal pain. Anything that's on the severe side, I think, would be alarm symptoms.
Yeah, I think those are really good. The only thing I would add to that would be waking up at night to have bowel movements. That's not typically seen with irritable bowel syndrome, so that's, to me, makes me think that there may be something else going on, infectious or otherwise inflammatory. And the other thing, similar to what you said about onset, is age of onset. If patients have had sort of a normal gut history in their 20s, 30s, 40s, and then start having recurrent or chronic diarrhea in their 50s or 60s or older, to me that was going to require additional investigation, like colonoscopy, maybe even imaging. The one symptom I didn't mention, and we'll kind of get into a little bit of some treatment principles next, is bloating. And while not strongly emphasized in Rome 4 criteria, it is seen a lot. Gas, bloating, belching, flatulence. Do you see that in your patients? I mean, that's a big complaint, isn't it? Huge. Yeah.
I mean, huge. You don't, like you said, you don't read about it much in the Rome criteria and other things that you read about with irritable bowel syndrome, but it is extremely common, especially on the constipation side of it. But it's very, very common, the bloating and the gas and the flatulence.
Yeah, and also is one of the most bothersome, obviously, one of the most bothersome and potentially embarrassing symptoms for patients, so worth really addressing and acknowledging when we talk to those patients. Thank you guys as always, and we wish you good health as you navigate these sort of tough waters in this COVID-19 pandemic. So be safe, be careful out there, and from the shadow of Vulcan, right back this way, stay regular.